Welcome to Uncovering Health Disparities, Racial Equity and Substance Use Prevention in Minnesota. This is a webinar being put on by the Minnesota Prevention Resource Center. Today we hope you will leave knowing a few different things. First, what the opioid epidemic in Minnesota looks like, and more specifically, what significant racial disparities exist within it. We also hope that you'll leave knowing the important context and the factors which contribute to these disparities. And again, for any of you who are recently joining us, if you have background information about some of that context that you would like to share, we invite you to type that into the chat box as we go through the beginning of our presentation this afternoon. Third, you'll be leaving today with a few practical ideas for how you might implement what you've learned in today's presentation in your existing substance use and misuse prevention strategies by applying a racial equity lens. And what does that look like? What might that look like in what you're doing in community? We would like to start by doing some introductions. I'm going to have our presenter, Nate, start introductions off. So Nate, I'm going to unmute you. And if you would introduce yourself. Go ahead.
Yes, thanks. Hello, everyone. My name is Nate Wright. I'm the lead drug overdose epidemiologist in the Injury and Violence Prevention section at the Minnesota Department of Health. I help to lead and coordinate a number of our opioid overdose prevention activities, kind of more from the data side, so helping to lead the analysis that describe, define, and help us understand trends in drug overdose, drug use, drug morbidity, and mortality more broadly across Minnesota.
Great. Thank you for being with us, Nate. We intended to have Jackie Dion also present with us this afternoon. She is the Director of American Indian Health and the Tribal Liaison for Minnesota Department of Health. Unfortunately, Jackie had sort of a last-minute unforeseen scheduling conflict, so she encouraged Nate and I to go forward with this presentation without her today rather than to try and reschedule on all of you who had registered for today's webinar. If you have questions for Nate or for Jackie, please direct them to me. I'm Lindsay Smith, the other person you see on the screen right now. Please direct any of those questions to me. You have my contact information through registration, and I will get you connected to them. So Jackie is still at your disposal, just not with us presenting today. Like I said, my name is Lindsay Smith. I'm the project director for the Minnesota Prevention Resource Center, and I'll be serving as the moderator today. Which brings me to just a couple of housekeeping items. There are a couple of ways to communicate with us today. If you need help with something, if there's some technical glitch happening, feel free to select that raise your hand icon that you see on your screen, and I will send you an individual message and troubleshoot with you anything that's going on. The other thing to know is there are two ways to interact with us. We have a couple of chat box questions, so when you see that icon, know that we're inviting you to type your response into the chat box. We also have a couple of polls today, so be on the lookout for those. We'd love to hear your feedback or hear your ideas, your guesses to the questions that we have throughout the presentation today. Also know that we are recording this webinar this afternoon, and that will be available to view if you'd like to see this again or to share this with others. You'll be able to view and share the recording soon at the link on the screen. With that, I am going to pass it off to Nate and have him lead us through this afternoon's presentation.
Great. Thank you very much, Lindsay. I assume I have presenting controls now to move the slides and whatnot?
You do.
Perfect. Great. So thank you again, everyone, for joining us this afternoon on this webinar. I'm looking at the race rate disparity in drug overdose mortality in Minnesota. So, of course, I will get into some of the data and analysis specific to this in Minnesota and help us to further understand different trends and findings that we're seeing with our with the analysis. But to begin with, when we're talking about the drug overdose disparity, we really need to take a few steps back and understand why this report is needed, who is included in this report and who is not included in this report, and further understanding how a drug overdose death is determined by the medical examiner and coroner. And this is important contextual information that we need to take into consideration before we get into the analysis to help us understand and understand the meaning behind some of these data and numbers as well. So to begin, looking at why this report is needed. So African American and American Indian populations are dying from drug overdose deaths in Minnesota at disproportionate rates compared to whites. All program and policy decisions about substance use disorder must include a racial equity lens in order to address the race-rate disparity within the African American and American Indian populations. These data and information are intended to inform the opioid epidemic response and substance use disorder prevention efforts. The race-rate disparities in drug overdose death mirror other racial disparities in Minnesota in, for example, graduation rates, infant mortality, poverty, incarceration, removal from home, unemployment, home ownership, and suicide. So who's included in this report? So this this report is an analysis of disparities based on race within Minnesota, focusing on drug overdose deaths. So this report does not focus on other outcomes related to drug use or misuse, such as non-fatal overdose or opioid use disorder treatment, or more broadly, substance use disorder treatment. So the three groups included in this report are African American, American Indian, and whites. Other racial groups are not included because they have generally lower drug overdose mortality rates relative to the white population of Minnesota. And then how a drug overdose death is determined and counted. So the drug overdose death data that I will be presenting come from the Minnesota death certificates. And so after a death occurs, a death investigation is completed, generally along with an autopsy and complete toxicology testing. And then with this information, the medical examiner or coroner makes a determination of the cause and manner of death. And the medical examiner or coroner lists the specific drugs on the death certificate that were determined to be involved or that played a role and caused the death. And for further information and more in-depth kind of background on how a drug overdose death is determined, there is additional information available on the opioid dashboard, which I will get to here in a few slides and look at when we look at the disparity in more depth. But there is a special topic on the opioid dashboard that focuses on drug overdose death reporting and how a drug overdose death is determined and counted. And this special topic I'll highlight on our way to the other special topic as well, is under the narrative tab of the opioid overdose death section. So I'll also bring your attention to that when we move to the dashboard. So kind of further talking about or understanding some of the context and factors that are relevant to the drug overdose race rate disparity that we see here in Minnesota. So overall, Minnesota has a relatively low drug overdose mortality rate, and this is when we're comparing Minnesota with the U.S. or with other states within the U.S. So when we do that comparison, Minnesota does not generally rise to the top as a state needing extra support or resources to address the opioid epidemic. So in other words, it appears that many states are suffering even more from the opioid epidemic than Minnesota. However, when the mortality rate is divided by race, then the disparity between whites and African Americans and between whites and American Indians is seen. So for some further context as well and understanding, so in Minnesota, African Americans make up about 7% of the total population, and American Indians make up about 1.5% of the total population. So if we look only at the number of drug overdose deaths that are counted, the number would be relatively small in these populations compared to whites, simply because of the low percentage of the population overall. So that's why we really look beyond just the numbers and thinking about rates. And I will, and that kind of plays a role in how we're presenting some of the data on the opioid dashboard. And another, concept to understand or consider is polysubstance use. So polysubstance use is the intentional or unintentional consumption of more than one drug at once. And so polysubstance use may occur when multiple prescriptions are being taken at the same time, such as benzodiazepines and opioids. A prescription medication or drug is being taken along with an illicit drug. Multiple illicit drugs are being taken together, such as methamphetamine and opioids, or one illicit drug is laced or mixed with multiple other illicit drugs, such as heroin mixed with fentanyl or methamphetamine mixed with heroin. And another recent trend is in counterfeit prescriptions that are mixed with cocaine, fentanyl, and/or carfentanil, other potent opioids. So when someone buys a counterfeit prescription or illicit drug on the street, the individual purchasing this is unaware of the actual drugs contained in the counterfeit prescription or illicit drug, and this puts the individual at potential increased risk for overdose. And also important to consider kind of understanding self-medicating. So self-medicating is when people take medications and or drugs that they have self-selected rather than been prescribed to cope with mental health symptoms, physical pain, and or trauma. There are many reasons why these populations, or African American and American Indian populations, are dying from and using prescription and illicit opioids to self-medicate, including, but not limited to, a higher incidence of historical trauma, higher incidence of adverse childhood experiences or ACEs, lack of access to medical care and or non-opioid treatment options, stigma in pursuing chemical health treatment and recovery supports, lack of access to culturally responsive treatment programs, lack of trust with Western medicine interventions, failure to appropriately diagnose physical or mental health symptoms, lack of research about the effectiveness of interventions with people of color or American Indian communities, access to illicit drugs within the community, racial bias on the part of providers who prematurely and or abruptly discontinue opioids, illicit drugs. The illicit drug uses are currently addressing symptoms and cultural acceptance of sharing prescription medications among family and friends. And then finally, understanding the social determinants of health. So the realities of poverty, racism, classism, social isolation, sexual exploitation, and other social inequities affect people's vulnerability to and capacity for effectively dealing with drug-related harms. Risk factors for developing a substance use disorder add up over the lifetime, starting with historical trauma, genetics, substance exposure during pregnancy, adverse childhood experiences, early exposure to drugs, and social context where drugs are used, and early initiation to drug use. For example, if a person has a good paying job, safe living environment, and quality health care, their ability to seek treatment for medical, mental, and chemical health needs is greater than a person who is financially struggling, living in toxic or unsafe conditions, and lacks health coverage. Conditions of life are connected to outcomes, especially when it comes to the treatment of chronic pain, mental health, and trauma. Life and health potential is affected by a countless number of factors, down to the quality of the mattress a person sleeps on, to the quality of the shoes someone stands in all day, to the price of copays for medical treatments. So now I kind of, with that further understanding and context about this, about the race rate disparity, I am going to switch over to the let's see, the opioid dashboard itself and this special topic. So
I'm gonna pose a poll in just a minute
Oh, I'm
before you
sorry.
do
Yes.
that, Nate.
Yes.
And before I do that, thank you so much for sharing all of that great information. That's such an important precursor to the data that you're going to share. I know for our audience that was a lot to take in a short amount of time. So I'm curious if there are one or two main sort of summary points for you that stand out, Nate, as you've worked with this report and you've worked with this data. Are there a couple of key things that you think or reasons why all of this context is so important?
So it kind of it speaks to the larger understanding that the factors that play into the disparity. So thinking about you know, kind of, I guess, going through each of the points I mentioned, looking at polysubstance use and self-medicating and the social determinants of health, that really there are larger social or community factors that play into this that we need to consider, and that these factors are kind of manifesting in these outcomes, not necessarily they're directly related to these outcomes, and these communities are disproportionately impacted by some of these inequities that we are seeing. So
right, exactly.
It's important to keep that in mind, and that understanding that why this report is needed, because these populations are dying from drug overdose deaths at disproportionate rates compared to the white population in Minnesota. So that's, and this is happening because of these larger, some of this is happening because of the social factors that are playing into this.
Right, exactly. Great. I think that's helpful sort of summary point for all this.
Yeah.
So before we move into some of the data that Nate's going to share, I'd like to open our first poll, which is, compared to all other states in the U.S., where do you think Minnesota ranks regarding the disparity that Nate started to describe, regarding this disparity between Native Americans and whites? And the second question will be basically the same, but related to the other population we'll be looking at, which is African Americans compared to whites. So if you'll take just a minute, I see several of you have started to respond. Compared to all other states in the U.S., where do you think Minnesota ranks? One being we have the greatest disparity, and then on down. If you'll take I'll give just another 30 seconds to get responses. We have about half of you responding so far. Best guess. This just kind of is a precursor to what it is that we want to share, and we just thought this would be a good way of grounding everybody in what we're going to share. Let's see where you all are at. Okay, I'll give just another couple of seconds. I am going to close the poll and share the results with you. So we have quite a mix of what people are thinking at this point. About 18% of our group, those who responded, think that we're pretty close to the top at either 2 or 4th greatest disparity, but quite a lot of mix of what people are thinking. So the next poll, the same question. Where do you think Minnesota ranks related to this disparity between African Americans and whites? Again, I'll give you just another 30 seconds. We've got about half of you responding. Okay, I will display the results and close the poll. So it looks like people are thinking that the disparity between African Americans and whites in Minnesota compared to other states might be a little less great than the disparity between Native Americans and whites. So thank you for sharing kind of where you're at with us. Nate will share the actual answers to this in just a minute when he shares his screen. So thank you for just letting us know where you're at. Nate, I'll have you go ahead and click the button at the top that says Share for you to share your web browser and start going through the data.
Got it. Here. So this is the opioid dashboard homepage. So if you have not been to the dashboard before, this is kind of a one-stop shop for statewide data related to opioid use, misuse, and overdose death prevention. So there's a number of data resources, downloadable graphs, and analysis on this for you to as a reference. Our contact information, as you can see, is at the top there. So this is kind of our one-stop resource for all this information. So then moving to the opioid overdose death section, if you click on the blue italicized indicator, the total opioid overdose deaths, that opens up the section itself. And this kind of formatting is the same across all the different sections on the dashboard. And then under the narrative tab, there are some special topics. So as I had mentioned before, the death reporting one, the first link is details how death is counted and reported. So if you have further questions about how overdose deaths are counted, that would be the place to look. And then as you can see, the third link there is the race rate disparity, an analysis of disparities in looking at drug overdose death. So that brings us to the race rate disparity special topic page. So this is its own unique web page, so you can send this direct link out to this report if there's any interest there. And at the top of the report as well, there's a link to a PDF downloadable version of this report too for other distribution, or just to save a copy of it as well.
Great.
So the report, the page begins with a lot of the context that I just kind of overviewed through the slides at the beginning of this presentation, talking about why this report is needed, who's included in this report, and then how a drug overdose death is determined and counted. Then as we scroll down to some summary points about kind of key data points and takeaways, which I'll get into with some of the further information below. And then again, we're making sure that the context, the information is included below that, looking at the understanding the race rate disparity, the polysubstance use, self-medicating, and understanding social determinants of health. And then we come on to the kind of 6 key data analysis highlights regarding the drug overdose disparity in Minnesota. So if you click on the blue link, the indicator opens up, and each of the analysis is within both of these. So to begin with, when we look at drug overdose mortality at a statewide level in the U.S., we see that it varies widely across the U.S. in a number of states. And these are 2016 numbers here. So we see that it ranges from the high of 52 per 100,000 in West Virginia, all the way down to Nebraska, which is about, I think, 6.4. You can see the total U.S. rate in the middle there at 19.8. And then near the bottom, you'll see Minnesota at 12.5 per 100,000, the overdose mortality rate. So as I mentioned, we don't really, Minnesota overall doesn't really come up near the top as needing extra kind of attention or resources in regards to the drug overdose epidemic. By a look at overall state view, we look pretty good compared to some other states in the U.S. So then moving on to the second indicator, or data key point from this is that Minnesota's overall drug overdose mortality rate masks racial disparities. Minnesota, as you saw before, we ranked 11th lowest among all states in the District of Columbia in drug overdose mortality rate in 2016 at 12.5 per 100,000. We had moved slightly higher in the rankings compared with 2015, where we were about 5th lowest, but still kind of among the lower rates in comparing the different states. But the increasing trend in drug overdose mortality rates in Minnesota similarly parallels continued increases across the U.S. And then we see with the first graph here the drug overdose mortality rates by race. And that in 2016, African Americans were 2 times more likely to die of a drug overdose than whites, and American Indians were almost 6 times more likely to die of a drug overdose than whites. And so while Minnesota has a generally lower overdose mortality rate, we have some of the worst race rate disparities in drug overdose mortality rates in the nation. As I mentioned, the African Americans were about twice as likely, and the American Indians were about 6 times more likely to die of a drug overdose than whites. And the disparity between Native Americans and whites is the greatest rate disparity based on race in the United States, and the rate disparity between African Americans and whites is the second greatest rate disparity based on race in the United States. So speaking to the poll questions that were asked just before, these disparities are the greatest or second greatest in the country. And so then moving on to the third kind of key data point from this, we see that now the previous data point was just looking at more recent data, 2015 and 2016, and seeing how the state rate masks the race rate disparity. But now we kind of look at a little further back in time and seeing how the changes in drug overdose mortality rates over the past 6 or 7 years, and some of the trends that we're seeing in these rates. So we see that the drug overdose mortality rate has increased for all groups, and the race rate disparity has grown more disparate from 2015 to 2016. So you can see that by the fact that the distance between the lines among the groups has grown. So whereas the white rate has been relatively flat, maybe a little bit of an increase in recent years, that increase has been much greater in the American Indian and greater in the African American population. So that gap between the lines has grown. And the American Indian, from 2010 to 2016, the American Indian overdose mortality rate increased 123%. The African American mortality rate over the same time period increased 105%, and you can see that in the table below the graph. So it changed for the American Indian from 29 per 100,000 to 64.6. For the African American from 11.7 to 24, representing these 123 and 105% increase respectively. And so that rate for the American Indian was almost more than doubled across this time period, and was almost 6 times as high as the white rate. And the African American, again, about doubled over this time period, and was 2 times as high as the white overdose mortality rate over this time period. So just kind of showing that the ways that these drug overdose mortality rates the disparities have kind of continued and grown in recent years by looking at these trends over time. So on to the fourth point here, looking at the age distribution of drug overdose deaths. So we see kind of different distributions in the drug overdose deaths among these 3 populations. So the American Indian deaths are primarily occurring within the 25 to 34 year age group, and you can see that kind of that blue line, the younger peak in that distribution of overdose deaths. African American deaths are primarily occurring kind of an older group in the 45 to 54 year age group. And for whites, the purple line, it's kind of a even distribution in the 25 to 54 year age group. So it appears that there are different populations being impacted by the drug overdose deaths depending on the group, American Indians, African Americans, and whites. So and these call for potentially different responses based on these different age distributions in overdose deaths. And then moving on to the fifth category, or the fifth key data point here. So this it can kind of be somewhat a difficult point to view on the website, and so it's often have to kind of zoom out a little bit to see everything. But overall, so for whites, African Americans, and American Indians, opioids are the leading cause of drug-involved deaths. Over the last 15 years, however, there were increases in all drug categories, including benzodiazepines, psychostimulants, most commonly methamphetamine, heroin, and synthetic opioids. Synthetic opioids being fentanyl analogs, the more synthetic manufactured opioids. So these number of graphs that you see below here, so the first set of graphs that kind of go in pairs, we see that the first one is, these are looking at white residents, and this is looking over the period from 2002 to 2004. So we see that in the green bar there, the other opioids and methadone, think of that as the commonly prescribed opioids. That was had the highest rate of drug overdose death involvement in this from 2002 to 2004, or that 3-year time period. When we kind of move forward to more recent time, the graph right below that, in 2014 to 2016, we see that we've seen increases across all the different categories. We've seen increases across all of them, kind of apart from cocaine-involved deaths, which remained relatively stable. But we see increases in psychostimulant, benzodiazepine-involved deaths, and all across all of the opioid categories, the other opioids and methadone, synthetic opioids, and heroin. So that's kind of a snapshot of the overdose deaths among whites. We move on to the graphs below that. And again, these are kind of in pairs, so looking at whites. Then we move to African American residents. Again, we begin with some of the more distant data here from 2002 to 2004, some of the older data. We see that in that first time period there, cocaine-involved deaths had the highest rate of overdose death, followed by the other opioids and methadone, commonly prescribed opioids category, and relatively and low rates among the other drug categories, or no rate of 0 in some as well. And then again, when we move to the next graph, 2014 to 2016, we see that there are increases in all drug categories, particularly in cocaine and heroin-involved overdose deaths. So again, the psychostimulant-involved deaths, benzodiazepine-involved deaths, and cocaine-involved deaths all significantly increased across this time period. And within this, heroin was the leading cause of opioid-involved deaths in 2014 to 2016, and were involved in about 54% of all drug overdose deaths in this from 2014 to 2016. So a significant increase from the older time period. So really seeing that shift in trend in drug overdose deaths among the African American population in Minnesota. And then finally, moving to the last set of graphs here. These are the American Indian population. So as we had seen before, in 2002, from 2002 to 2004, other opioids and methadone, that commonly prescribed opioid category, had the highest rate of drug overdose deaths, followed by cocaine and synthetic opioids, and some very low rates in other categories. And then when we move to the more recent data, 2014 to 2016, we again see rates increase in all drug categories, particularly psychostimulants, which are the methamphetamine-involved deaths, synthetic opioids, the fentanyl and fentanyl analogs, and heroin-involved deaths, the red line. And in this group, heroin was the leading cause of opioid-involved deaths, and opioids were involved in about 70% of all drug overdose deaths from 2014 to 2016 among the American Indian population. So this is trying to, kind of helping to describe some of the different trends that we're seeing in specific categories of drug overdose deaths, not just looking overall, but how they have changed among these common drug categories across this time period, where we've seen some a great increase in the illicit opioids, being the synthetic opioids and heroin, as well as psychostimulants, primarily driven by methamphetamine as well. So that's and the ways that these kind of differ across these groups as well across this time period. All right, so then moving on to the final key data point from this is looking at the drugs listed on death certificates. So this is looking at the specific number of drugs that were listed on the death certificate. So looking at specific kind of textual information that's included there, and we see that greater percentage of American Indian and African American drug overdose deaths involved more than one drug compared to whites. So 60% of drug overdose deaths among whites involved greater than one drug. 62% of overdose deaths among African Americans involved greater than one drug. And 67% of drug overdose deaths among American Indians involved greater than one drug. And knowing that there are multiple drugs on the death certificate has several implications, including that addressing an overdose is more challenging when multiple substances are present, especially if there are opioids and non-opioids mixed. And tapering, withdrawal management, and treatment have additional considerations when polysubstance use is present as well. And it also kind of, another important fact to keep in mind, consideration is, medical examiners and coroners must know what drugs are available or are common in a community in order to know what to test for in toxicology during the investigation and autopsy. So perhaps there were some drugs that may be missed without understanding of what to look for, but it's just an important fact that some of this toxicology information is kind of an understanding of what's going on in the community at any given time as well. So that kind of, and then finally at the end we include a number of some more links for more information on some of the intersecting topics. So a link back to the dashboard itself, looking at the MDH Health Equity Report, pain management. As you can see, the kind of list of additional resources here, all available through and on the opioid dashboard, as well as then the final link there is a report to our or a link to our report looking at drug overdose deaths among Minnesota residents over the past 16 years. So if you kind of further information or questions in regards to this, these are great resources to start with and kind of help further information. And if you have any other additional questions, our contact information was on the homepage of the dashboard as well. So that's another place where you can connect with us, and we can hopefully provide some further information on this topic as well. So that kind of concludes my overview of the dashboard itself. So I hope that was kind of informative and kind of broke down some of the different trends that we're seeing in the race rate disparity in drug overdose mortality.
Definitely. And I'm going to take this opportunity to invite anyone listening in to, if you have questions that are coming to mind right now after seeing all of that data that you'd like to type into the chat box, feel free to type that in right now. We will have some dedicated time in just a little bit for Nate to answer more of your questions. So if you have questions percolating in your mind right now, I invite you to type them in so that we can start looking through those and make sure they get answered. So in the meantime, we're going to shift to that practical application element that we said that we hoped you would leave with today. Nate's shared a great overview of this data and what they're learning in this through this more in-depth analysis and looking at these disparities. We wanted to be sure that you had some examples for how you might use this information to apply a racial equity lens to what you're doing. So Nate, go ahead and shift gears to that, and then afterwards we'll open it up for questions.
Great, yeah. So kind of moving on to some potential factors to consider, examples to brainstorm from. So the first one I wanted to just mention, and I kind of touched on it before, but thinking about this, the distribution of funds and the question of numbers versus rates. So as I had mentioned that if we look just at the numbers of deaths in the American Indian or African American population, the numbers are going to be small compared to the white population or the kind of the entire Minnesota, simply because they represent a small proportion of the overall state, just in terms of the population numbers. And so kind of one way that we can help account for that is looking at rates. So taking into consideration the population size and standardizing our numbers for comparison so that we can make direct comparisons between the two populations to help us further understand disparities or identify disparities, and that can help us greatly in thinking about where the distribution of funds and how those are determined more than just numbers. And so this is this has played a role in some of our kind of some of the funding from a national level to Minnesota. That as I mentioned, that we don't come to the top when we look at states overall. We're relatively low, but we've really pushed that funding decisions from CDC or from other areas take into consideration more than just an overall state number, that they look further at different ways that you could break down or kind of stratify some of the analysis so that these disparities and clear need for future funding or future intervention and prevention initiatives need to be identified and can be done, can be looked at in these new and different ways, rather than just relying on a kind of overall state number, which it kind of masks some, which I showed can mask significant disparities.
Mm-hmm. And so for people who are working on, for example, a needs assessment or really looking into their community data, that's a good reminder to understand the difference there too, and good maybe additional good questions for Nate or for Jackie that you might have if you're in that process right now, or you'll be looking to do that process, is maybe some pointers on how to really differentiate when it's useful to be looking at rates versus numbers. Is that accurate too, Nate?
Yeah, absolutely. That's completely accurate, and kind of gets the example on the screen looking at data to support efforts for overdose or substance use disorder prevention, and ways that you can kind of take different data sources together and look at them in different ways to help kind of make these help needs assessment or funding proposals, and even thinking beyond just looking at overdose deaths, and even moving to some other indicators that can help further identify areas of need in the state. That's another way that we can kind of help to factors to consider as we think about this kind of racial equity lens in regards to overdose and substance use disorder prevention.
Great.
And so another kind of example to consider is looking at substance use disorder itself and the treatment models. So thinking about representation and culturally specific treatment, which is shown to be a real benefit and something that is kind of currently lacking. So understanding the population that needs access to treatment and those opportunities, and making sure that the treatment models are representative and culturally specific to the certain populations that you're hoping to hoping that you're working with and interacting with is a key component as well. As we've seen that there's significant disparities in overdose mortality rates, that we know that we need different treatment models and culturally specific treatment to help address some of these disparities. Mm-hmm. And then also thinking about kind of health in all policies, looking at program, policy, and funding, and continuing to keep this health equity lens within each of these, all of the policy decisions. And so that really thinking about advancing health equity is not about averages, it's about creating opportunities for everyone to be healthy. And knowing that this opportunity is not equally available for everyone everywhere or for everyone. And so making sure that we're kind of asking the right questions and thinking about, if we begin with equity as a starting point for decision making, how would that affect our work, and how our work would be different from what we're currently doing, and how that helps us to inform these decisions, I think is a key component as well.
Mm-hmm. I just want to add to that one a little bit. Something that I have continued to think about as we've been planning this session is that when I first met with Nate to start planning some of this, and we were thinking about what does this look like in practical application, one of the examples that was brought up that's related to the primary prevention end, that's a pretty common strategy related to prescription drug misuse and opioid misuse, is to have prescription drop box available as a solution for proper disposal of unused medication. And something that was brought up in the discussion as we were planning this session is, do those of us that are working on promoting those boxes and communicating they exist and the reason behind them, do we do a good job of promoting it to these audiences that are experiencing major disparities related to this problem? Are we promoting and distributing information about them kind of general public, or are we using some of these lenses to do that work based on what we know about what the data shows? And so examples like that, too, have really stuck with me as to, are there things that we're doing already that we are trying to advance and prevent these issues from occurring, but are we doing them with that lens? And so that's just really stuck with me because I had not thought about that before, looking at this data and hearing from Nate the breakdown, and it really made me think differently about even a strategy that's as common as drop boxes. So I just wanted to throw that out there because I think that adds to exactly what you're saying, Nate, about really thinking about this in all program and policy decisions that we're doing.
Exactly. That's great.
Did you have additional examples that you wanted to share?
The final example I included on the slide here is thinking more about kind of the looking at kind of discussion with some colleagues here and asking about other examples. So one of them they mentioned too is drug sales that are targeting tribal lands. So law enforcement agencies kind of in this intersects with some of the public health work too, with thinking about overdose prevention. Tribal lands can use additional resources to enforce actions or enforcement actions, such as seizures or investigations. They can use overtime and additional resources to investigate and to prevent these sales from occurring, because they know that they're targeting tribal lands and that these areas are at increased these increased risk for overdose and substance use, so that it's clear that there needs to be more kind of concerted effort focusing on these areas. So that was just a kind of a final example that I wanted to mention too, about ways that this is being implemented across the state. Maybe it's not necessarily directly public health, but of course it intersects with a lot of the work that public health and prevention work is doing related to overdose and substance use. So I thought that was kind of an innovative. Right, innovative, but at least a novel way that some of this work kind of relates to a broader collection of work as well.
Definitely. Great. So with that, I invite you to type in what questions you have for Nate. What questions do you have about the data you saw? What questions do you have about the information that he shared leading to the context? What information or what questions do you have about how you might apply what you've heard today to what you're doing or what a next step might be? Take a minute to type those questions in, and we will spend a little time answering them. To get us started, Nate, what would be one recommendation you would give to any audience member as to maybe a first step with this information, or what a good way of sharing the report from the opioid dashboard might be if someone's listening in, they want to share this with a coworker, or they want to share this with a coalition member?
Yeah, I think the kind of key message and kind of quick point that to make. So as I mentioned, that our low relative overall overdose mortality rate really masks significant disparities, and these disparities are some of the worst or the worst in the nation. So that we really need to kind of have a more concerted effort on thinking about this racial equity lens when it comes to substance use and overdose prevention, because there are significant disparities in our overdose mortality. So just keeping that in mind, that when thinking about overdose and substance use, about the population that needs a focus and needs a future or further resources to address this as we think about overdose prevention. And just so keeping that kind of key, I guess, kind of one message is that just the state rate masks this significant racial disparity, and I think that's a good way to kind of begin some of the conversations about how we can best address this. And using the data that's available on the dashboard, I think, can help begin that conversation.
Definitely. If someone was interested in a different type of analysis with the data on the dashboard, I'm putting you on the spot a little bit, but are you or members of your team available to assist with that?
Yeah, so we can definitely assist or kind of answer questions about certain things the data can or cannot answer. So a lot of the data that I showed here was at the statewide level, but in other places we do have county level information available, or some sub-state data available, so that can answer more of a specific question about a certain county or a certain region. We can kind of help to answer that question either through data that are already available, or perhaps we can kind of run a quick little analysis just to see what we're finding with that. But there's please reach out and ask the question. Our contact information is on the homepage of the dashboard, so we were more than happy to kind of discuss further and help to provide, either if it's health department data or connection with another resource in regards to this topic. We're more than happy to help out.
Wonderful. Great. Well, with just a few more minutes remaining, again, invite you to write any questions that you have into the chat box. We will make sure that they get followed up on from Nate or from Jackie. Again, if you have questions for her as well, I'm sure she'd be happy to answer them. Before we run out of time, I would just like to share a couple of additional resources for you to be aware of, or opportunities for you to be aware of. If you have not been introduced to your regional prevention coordinator, they are a team of 7 who are physically located across the state in the various regions that you see the state broken up into on the screen here. They're available to help you with next steps. So they're available to help you brainstorm what you might do with the information that you heard today. They are available to help you think about who else to reach out to in your community to maybe create some partnership around moving something forward based on the topic that you heard about today. Or to learn what's already happening in your area related to this and how you might bring this information to that effort. So if you're interested in meeting them or reconnecting with them, they are your in-person support folks funded by the Department of Human Services, or a sister project to Minnesota Prevention Resource Center. So I wanted to be sure that everybody knew that that's available to you. Additionally, if you are interested in more learning opportunities like today, we invite you to take a look at our training calendar. The next webinar that we have scheduled is on April 2nd, and it will be on the topic of Tobacco 21 policy initiatives. So this is the policy that increases the sales age for tobacco to 21. And we will be diving into details about what you need to know about current policy initiatives, frequent questions that we hear both from community members and from community organizers on this topic, and then also the impact that this policy has shown to have on reducing youth tobacco rates. We also have 2 core prevention trainings that we offer on a regular basis. Substance abuse prevention skills training is one of those. The next one will be happening June 3rd through 6th in Bemidji. And the ethics and prevention training, which is a pair to substance abuse prevention, is happening next March 29th in Bloomington, and then also in June in Bemidji immediately following substance abuse prevention skills. So we invite you to go to our website, the link listed there, to learn more about those. And finally, our Minnesota Prevention Program Sharing Conference is coming up this fall. We encourage you to save the date. We'll be in Duluth this year, October 24th and 25th. If you are interested in applying to present a breakout session, I also invite you to think about a topic you are interested in sharing with your prevention colleagues. Applications are being accepted through March 29th, so you still have about a month to get an idea formulated and submit your proposal. All of the information about that you can find on our website as well on the conference page. So with that, I would like to thank Nate for all of the great information you've shared today. We really appreciate it. So thank you, Nate.
No problem. Thanks for having me.
Absolutely. And we hope everybody has a wonderful rest of the day. I'm looking out my window, and it appears that the snow, at least here in St. Paul, is starting to diminish a little bit. So we hope that you have a great rest of the afternoon. Enjoy the snow globe out there, and that we will see you again for another webinar or training. So take care and have a great one.